Ladies and gentlemen, dear ELPA friends, welcome to this roundtable discussion, which is happening now online. Usually, we had this event in the middle of the place where the decision makers are making decisions about health. But this year, because of the elections, we are doing it online. This means that we can also share it a lot more. It's a roundtable discussion about shaping the future of liver health, the strategies for early detection and intervention. This roundtable discussion is organized in collaboration with the Obesity Association and will aim to address the issues surrounding the early prevention, screening, diagnosis of fatty liver diseases. The event will try to combine healthcare professional view, researcher view, policymaker view, and patient advocates view in order to explore the correlation between fatty liver diseases, obesity, and metabolic disorders. By fostering knowledge exchange and collaboration, we are aiming to advance the strategies for effective prevention, early detection, and management of these interconnected health challenges. It's my distinguished pleasure that I can introduce you today to our speakers. So my name is Marco, I'm the president of European Liver Patient Association. And first we will have two scientific presentations. First presentation will be done by Professor Romero Gomez, and the second on alcohol and liver in the framework of the new SLD nomenclature. And the second presentation will be done by distinguished Professor Helena Cortes Pinto about how can we avoid getting a steatotic liver. Presentations will be followed by a roundtable discussion, and roundtable discussion will be managed by our head of Brussels office, Beatrice Credi. In the roundtable discussion, we have Professor Jon Schattenberg talking together with Mr. Jeff McIntyre from Global Liver Institute, of course, Alba Gill from IPHA, and Vicky Mooney from ECPO, and from a Fatty Liver Alliance. We are very happy to have Mr. Michael Bettel with us. And without further ado, I give the floor to our first speaker, Professor Romero Gomez. The floor is yours.
Okay, I'm sorry, I'm reconnecting. Are you listening to me?
Yes, perfectly.
Yes, we can hear you.
Okay, thank you. Thank you, Marco, for inviting me to be part of this roundtable. It's a great pleasure. I hope the European Parliament will be working, the next European Parliament will be working and supporting all our activities and all our fight against steatotic liver disease, the previous fatty liver disease. I'm trying to share with you a few comments and ideas about alcohol and the liver in the framework of the new steatotic liver disease nomenclature. I think it's a very important aspect. Next, please. And when in this scenario in which we were planning to modify the name because due to the stigma that promote both fatty and non-alcoholic, and to highlight the metabolic role of this metabolic dysfunction in this entity, at the end of the roundtable, we make a decision to classify in an umbrella steatotic liver disease, metabolic dysfunction, associated steatotic liver disease, muscle and MASH as the metabolic dysfunction associated steatohepatitis, and on the other side, alcohol associated liver diseases, and between both, we need to define a new entity, is the MET-ALD, that means people with metabolic disorder and alcohol consumption. Depending on the amount of alcohol people are drinking, we can go to closer to the alcohol-related liver diseases or closer to the metabolic dysfunction associated steatotic liver disease. For sure, we keep a subgroup of a specific etiology of steatotic liver disease, including cryptogenic, DILI, monogenic, or the miscellaneous. The next, please. When we are addressing this new nomenclature, we need to keep in mind at least two key aspects. One, on the left part, if the metabolic disorder. We need to analyze if our patient is showing or not metabolic disorder, both in the adults and also in the pediatric population, focusing on obesity, body mass index, on insulin resistance and glycemic control, mainly pre-diabetic and diabetes, the arterial hypertension, the hyperlipidemia, and also the low level of HDL that could be a major factor promoting cardiovascular risk. On the other side is to analyze exactly what is the amount of alcohol our patients they are drinking. We can ask questions during our interview: how much alcohol do you drink? In general, do you drink more than you should? It's a very good question, because it's the patient, the self-patient is analyzing if the amount of alcohol they are drinking is more or not than they should. But we can use questionnaire like Audit C is a very short questionnaire, just 3 questions that could allow us to understand if our patient is drinking in a dangerous manner. For sure, we can use biochemical parameters routinely available, like GGT, HTLT, macrocytosis, or the ANI index. And finally, we have a very hot topic on discussion about the direct biomarkers of alcohol consumption. We can measure blood alcohol, CDT, carbohydrate deficiency transferrin, or phosphatidyl ethanol, the PEth, and the ethyl glucuronide. For sure, this biomarker could allow us to better identify patients drinking alcohol and the associated liver disease, but for sure could be embarrassing implementing in clinical practice. The next, please. This is the pathway in the decision making for the new nomenclature, where all these aspects that I as previously commented were addressed, mainly the stigma and also the alcohol consumption. Next, please, because addressing alcohol is very important. All of us know that alcohol-related mortality is a very important cause around the world, and mainly digestive diseases, but also social and psychological disorder, unintentional injuries, suicide, intentional injuries, but also related to malignancy, epilepsy, or cardiovascular diseases and diabetes. That means, for sure, in this outbreak, we need to address, and the next is to trying to put on the next, please, the in the same scenario that at the end of the day, the final damage of the liver and also the rest of the organs depends on 3 main aspects. One of them is the amount, the alcohol consumption, but a second one is how can we metabolize this alcohol? Could our microbiota produce alcohol, endogenous alcohol, that could be also dangerous? And finally, the personal susceptibility that could be linked with the genes and the microbiome. We know that no safe limit for alcohol consumption and risk of cancer. You can see, next please, in this fantastic work, including 100,000 of people around the world, how starting with just 1 unit of drink per day increase the risk of cancer, and that means that no safe vessel is available for the use of alcohol. The second, next please, alcohol in patients with liver diseases. For example, in this cohort, patients with NAFLD and advanced fibrosis, F3, F4, they could show a completely different prognosis if they are drinkers or non-drinkers. That means that in spite of all of them were drinking a very low amount of alcohol, it's completely different the prognosis between drinkers and non-drinkers. Next, please. That means we need to include alcohol in our daily clinical practice. We need to advise the patient. We need to analyze consumption, but at the same time, metabolism, susceptibility. And after that, we can address much better with this new nomenclature, this major issue in liver diseases and also in the general health, in the public health of the population. Thank you very much for your attention, and thanks to the people belonging to my team.
Thank you very much, Professor Gomez. It was a pleasure listening to you, and we will get back to the alcohol and liver topic in the second part during the roundtable, with a specific focus on the complexity in diagnosing and treating patients. But now I would like to give the floor to Professor Pinto, who is, I mean, it's a pleasure to have you. I mean, she's a friend of ELPA, so I'm always happy to see her, and she will go into more detail about the current trends of the disease, the early detection and the prevention of the disease. Professor Pinto.
Thank you very much. Just let me know if you hear me okay. Okay.
Very okay.
So first of all, thank you to ELPA for inviting me to be here. And it's my pleasure to be in this roundtable to discuss this issue that is so dear to my heart, because in fact, I've always been interested in steatotic liver disease in its two components, in the non-alcoholic and in the alcohol-related. So next, I changed a little bit the title so to go more with what I've been asked: steatotic liver disease prevention and early detection. Next, it's just my disclosures. And next, so I will not be here much more because, of course, Manuel told us all it was needed, just to emphasize a little bit more about the importance that this new nomenclature brought with the possibility of having this name of MET-ALT, where it is considered that, in fact, a large majority of patients of individuals have simultaneously the cardiometabolic risk factors and also some alcohol consumption that can be rather not so high, and so it is muscle predominant, or it can be a much higher predominance of alcohol consumption. And so we finally had a possibility to consider the spectrum, the umbrella of both issues that cause steatotic liver disease. Next. I think so. This is again the adult criteria. Of course, it is obesity, it is diabetes, it is hypertension, and it is lipidemia. Next, so I will move to the next because this is what we already have discussed. And so I will focus a little bit more on the last data we have from the global epidemiology of non-alcoholic fatty liver disease that we now called steatotic liver disease, so MASLD, metabolic associated steatotic liver disease. And in fact, it is quite impressive that about 1/3 of the population has this disease. It is more frequent in some areas of the world, like Southeast Asia or South Asia, but it is also very frequent in Europe. And of course, we do not know exactly to which extent this prevalence of NAFLD, if we now move it to MASLD, I'm sorry, can you come back to the last one? To which extent some of these patients also had higher consumptions of alcohol than it is stated in these large inquiries from the data that is taken and published. So probably this includes, to some extent, also people with metabolic risk factors. Next. And so we have two major issues that are causing steatotic liver disease. And besides from alcohol, that we will discuss more during the roundtable, I think that the two most important problems is the obesity and the diabetes. And of course, we know that diabetes is in large part related with the prevalence of obesity. And as you can see here, obesity has been increasing during these last years and is predicted to go on increasing. Next. And diabetes is also increasing very much. This is some data on the left from a study that's called Health 1 that was done commissioned by ISL, and that shows the high prevalence of type 2 diabetes in Europe. And next, if you see the predictions for the increase in diabetes, it is quite impressive what we are to expect in 2030 and in 2045. So what we have now is a problem that has been increasing through the years. And what we have to focus on is how can we change the tide. Next. We also know that from 1990 to 2019, there has been a marked increase in the prevalence of deaths and the prevalence and incidence of MAFLD and MAFLD-related HCC. And this is data from the ISL Lancet Commission, a fantastic document that was produced by ISL and that I recommend all to read. And I will show some more slides from this document. Next. And so the prevalence of MAFLD and of MASH, and now I'm already using the novel nomenclature, but it was very well shown that we can use the new nomenclature even from the data from old studies, because the prevalences are almost similar if you think of MAFLD or NAFLD or NASH or MASH. And so in this data from QUEC that was published last year, from a pooled analysis comprehending about 100,000 individuals, you see that, so here I use NAFLD, but we can use MASLD in the overweight population, and NASH in the overweight population are really very, very high in percentage, coming from 69 to 99, and NASH from 33 to 50%. And what is interesting is that this prevalence, although it's a little bit higher in obese population, either NAFLD or NASH, but the overweight population is also already a very important high risk. So even if you consider that obese are the population that are your major target, also being overweight is an important risk factor. Next. And the UEG during the last year was published the White Book 2, where it was investigated the burden of digestive diseases and what were the priorities for digestive health research. And as you can see here, the burden of digestive diseases is very much based on modifiable risk factors. And these risk factors very much include alcohol use, drug use, smoking, and high BMI. So it is very important to have in mind that most of the liver diseases are due to modifiable risk factors. Next. And cirrhosis and other chronic liver diseases have the higher number of years of life lost among 44 EU members in 2019. So if you compare cirrhosis with all the other digestive diseases, it's very, very impressive how much more years of life are lost due to cirrhosis. And that's in large part due, next, to the fact that patients dying from liver disease die early. So there is very much of premature mortality that here it is shown in this dark bars compared to other digestive diseases. Next, this is also shown in this slide, again from the Lancet Commission, where if you compare, for example, the patients that die from alcohol-related liver disease, here shown in green, with those that die of type 2 diabetes-related liver diseases, or with cancer, lung, trachea, and bronchus, the patients with alcohol-related liver disease die much younger. And so the burden in years of life lost and the economic burden is much higher for alcohol-related liver disease. Next. This is also shown here in the premature deaths due to liver disease, either due to alcohol consumption, that is the gray bars, or those due to alcohol consumption, the blue, the light blue. They are very much important in most of the countries in Europe. Of course, much more in the Eastern countries and less in other countries. Next. Next. Another data that shows the great importance that steatotic liver disease is either associated with alcohol or associated with NAFLD is that both causes of steatotic liver disease remain the main indications for liver transplantations. So we have to focus on these two causes of steatotic liver disease that need to be addressed so that we can reduce terminal liver diseases that need liver transplantation. Next. So again, ESL commissioned this important study that is the EPA Health 2 that tried to show us what were the best policy measures to tackle simultaneously the two major risk factors for steatotic liver diseases. So here we studied 3 countries, just as an example. It was France, the Netherlands, and Romania. And what was done is to estimate the impact of several policy interventions that targeted alcohol and obesity in the incidence of chronic liver disease and also of primary liver cancer. And what it was found, it was that the best scenarios for reducing these steatotic liver diseases are simultaneously increasing the minimum unit pricing. That basically is a policy measure that makes a ceiling of the price that alcohol can be sold. And so it has a great impact on the alcohol drinks that are consumed by people that have alcohol dependence, and simultaneously introducing policies that target, for example, sugar sweetened beverages. So this targeting, this increase of taxes, either in alcohol and in this kind of beverages, lead to a significant decrease. I'm sorry if this is too small, but using both policies, what can be in fact seen is that this should bring to a decrease in either chronic liver diseases and liver cancer. Next. So the take-home messages is that first, it is very common the association of excessive alcohol consumption with obesity. and it is increasing. It increased in the last years, and if we do not do anything, it will go on increasing. And also that there is synergism and a superadditive effect of hazardous alcohol and the presence of obesity and metabolic syndrome, either to the existence or to the progression of liver disease and hepatocellular carcinoma. And public health measures must target both risk factors, and of course, patients should be mostly screened and managed according to their risk factors. And I hope I will have the opportunity to discuss more in the roundtable. And this is my last slide, the next. So please go to the next. That's also a very important slide from the Lancet Liver Commission. And what it shows is that if we start by the right is we should change the way we see liver diseases to increase prevention, screening, and early diagnosis to be our first target instead of management of complication. And if we now go to the left, it is in fact at the population level policies, as we already mentioned, the fiscal marketing and the vaccination, and less on the clinical intervention, although these are very important, such as diet, and of course, all the other issues to reduce liver disease. And we hope that in the future, we will have less need of hospital-based treatment of cirrhosis and complications if we make the bigger emphasis on prevention, either in this case of obesity and of alcohol. Thank you very much, and sorry for taking a little bit more of time than expected. Thank you.
No problem, Professor Pinto. It was very interesting, and it's the perfect conclusion to then delve into our discussion. So I will invite everybody to switch their camera on, just to have the feeling that we are all together, even if this year is not possible. And I think that the last slides by Professor Pinto were extremely important to start the discussion, especially because I would like to start the discussion with Alba Gil from IFA. And I would like to sum up two important messages that were in Professor Pinto presentation. The modifiable risk factors of the disease, the increasing global trends of obesity, diabetes, the correlation with the disease with liver cancer. And I'm very happy that I can discuss this with Alba, because Alba is an expert in food systems. So I'm very happy that to address the first question to her, because also as patient association community, we put in place many initiatives on personal habits. You have to modify your lifestyle, you have to drink less, you have to practice more sport to mitigate all the risk. But we have the impression that there is less focus from policy making on the fight against the commercial and the social determinant of health that are responsible for non-communicable disease. So how do you see the civil society advocacy in this field? And thank you for joining us. This is your first time, and welcome to Alpa family.
Thank you very much. Thank you very much for having us and for having me. It's a pleasure to be here. And indeed, it's a challenge, right? And we see it. If telling people you have to eat better, you have to drink less alcohol, and you have to move more worked, we wouldn't be here, and we would not have the increasing numbers that we see. It would be solved. And this is the message that we have had for the last 20-30 years, and it is not working. So it's only foolish to keep on repeating the same and expect different results, because again, this is not working. What would work, and what do science say that would work? To change the environment. and to change the environment where decisions and interaction with food is made. We cannot expect consumers and citizens to make healthy and sustainable choices when the environment is designed for making unhealthy and unsustainable choices by default. And now it's normal. I mean, look at marketing, for example, food marketing, food promotion. When you go to the supermarket, it's all designed so you buy the unhealthy product, which is also the most profitable for companies. And this is when the commercial determinants of health come into place. Commercial determinants of health, they don't need to be negative per se. I mean, it's a neutral concept. It's the interference of commercial practice into health. The problem is that usually it's negative because these commercial interests usually go against public health. And it is okay that health is not the priority for everyone. This is legit. What is not legit is that health is not the priority for policymakers. And this is what we need to change. And this is where health advocates we need to emphasize. Health must be the priority for policymakers because they have the mandate to make a healthy environment so we citizens can develop as citizens. And right now the environment is designed so you are unhealthy by design. So we must keep policymakers accountable for their promises. And here last week we published the manifesto with all the analysis of the European political parties' manifestos and what they promise on health. It won't come as a big surprise that health is not always measured and not always as much as we would like, but it's a start. And then we need to understand that there is no such a thing as perfect evidence. And this is something that we see with industry. They say, we don't have enough evidence. We need more evidence. This is a new kind of marketing. We need more evidence. This is not true. I mean, we have good enough evidence. And the European Scientific Advisory Mechanism, SAM and SAPEA, in food, they have said, we have enough evidence. Food environments work. Now we need action, and we need foster knowledge is wonderful, but foster action is what we reverse these numbers that we have seen, and we need to keep repeating it. Action, 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 and policies that there are wonderful policies written in the drawers that they could be published. The revision of the food information for consumers, the sustainable food system framework, the blueprint on the unhealthy food marketing for kids, for example, and this would have enormous impact on the well-being of citizens. So we need to understand that inaction perpetuates the problem, inaction perpetuates illnesses, and inaction perpetuates also and condemns vulnerable populations, because at the end, vulnerable populations are the ones suffering more from these illnesses.
Thank you. And I mean, I will ask a question, but if there is somebody who wants to make a comment, just raise an hand and we go with the flow. It's not a problem. I will be back now to the scientific field. And
I'm sorry, can I just make a comment?
Absolutely.
I completely agree with Alba. I think I'm not sure if I emphasized so much. But in fact, what we find over the years is that just saying to people the things doesn't solve, and it is policies, as this micro-simulation model of Apple Health 2 showed very well. And in fact, we already have the evidence from Scotland and other cities in other countries where MUP, and from Canada, where this was implemented. And this resulted in a reduction in the consumption of alcohol, for example. So I think it's in the policies, it's not enough saying to people, and the same with food. And I'd just like to say something that I think it's not very much written, and although I hope to try to do something on that. If you notice the film industry, you do not see any movie where the people are not drinking. You do not see any film. I'd like to make a study on that because I've just started noticing every woman when arrives at home, she takes a glass of red wine and she starts drinking it. If it's a man, he starts drinking some whiskey. Or have a drink or beer, of course. And if you seem stressed, so you will drink and drink and drink. And I think this is not something that has been spoken so much. And interestingly, with the tobacco industry, this was something that was also happening very much in the film industry. Everybody was smoking in the movies. So I think that's something for ELPA maybe to, I don't know, to someone should take the lead, because I'm sure it's not by chance. And I'm sure that the alcohol industry, that's very, very potent, and we have been seen over the years, they are having a very strong influence on this effect. I'm sorry, this is something apart, but
No,
I needed to say that because I think this has not been emphasized anywhere. And if all of you at least pay attention from now on, you will see there is no series, no movie where people are not drinking most of the time.
But just to give you another small details. Yes, no, just a quick thing about EU policy on this topic. And Alba can maybe complement on that. In the Europe's Beating Cancer Plan, all the action about NCDs are all delayed. Some don't even started to being discussed. This is the level of political willingness that we have in the EU about these topics. Also, can be interesting also for Michael and Jeff coming from not from the EU. Just for you to.
Yeah. Yes, to support, and I completely agree with Alba and Elena. It's a major issue. Even in the past, we were working on a law trying to regulate the diet and the alcohol consumption in Andalusia, but never was released due to many barriers, depending on the different politics parties. And it's very difficult. Even we have the opportunity to discuss with Carlos Moedas, as you know, Portuguese in charge of the science in Europe, highly motivated and highly interested in liver diseases. And we were discussing with him the possibility to regulate from the European Union point of view all these aspects that we are absolutely convinced that we need to do that. We cannot change education in the schools, the policymaker, the stakeholder, what are we doing every day in our outpatient office? We can address less than 0.1% of the activity. You know, that 99% it could be out. And I don't know, but I think ELPA is doing very well. It's working very well, and I think perhaps we can try to again go back to all these aspects we need to address. If not, at the end of the day, it could be very difficult to modify the morbidity and the mortality of these diseases.
Professor Gomez, keep your microphone on, because I have a question. Yes, I have a question for you. So coming back to the medical field, there is a project called Grip on Mesh that recently kicked off. So can you just give us some details about that? What are you doing and what do you want to achieve?
Grip on Mesh is a fantastic European project. It's an IR3 in which a partnership between the academy and the industry. And the main idea of this disease, the awareness, the detection, and the referral of the patient at risk of developing advanced liver disease at the risk of suffering the different extrahepatic malignancy and for sure liver diseases. It's a multidisciplinary team with a primary care physician, internal medicine, cardiometabolic risk factor expert, and covering more than 10,000 European people that could be screened. And after that, according to the guideline, the available guideline, we are moving forward, selecting patients at risk and developing new biomarkers to better understand both the diagnosis of the patient and also the prognosis. I think it's going very well. It's a we have the opportunity to include both ELPA and the European Patient Association, and I'm very happy due to this multidisciplinarity. The objective, they are affordable for us, and I hope it could be the second part, or if beyond the litmus, in which we were focusing on patients with liver diseases, and we did a fantastic trying to develop the best biomarkers, and now we are moving to the house of the patient. We are moving to primary care, we are moving to general population, trying to replicate the main concept that we developed in litmus in this clip on MASH. And I hope it could be highly useful, because it's connected with our previous discussion, because we are moving out of population in which the majority of our patients are suffering liver diseases, and explain why 50% of the liver cancer were not diagnosed in the screening program, but in patients that never were attended in our clinics.
Fantastic. This is the EU project, but we have the pleasure to have with us somebody,
Yes.
Jeff and Michael, who are not from the EU, so they can give us certainly a more global dimension of the disease and what is going on at, let's say, outside the EU framework. Jeff, I'm starting with you. Thank you for joining us from the US. I suppose that you are in the US. I think that you also, GLI recently published a booklet with best practice from around the world. And I would like you to share with us any best practice or lesson learned from the GLI work that could also benefit other organizations that are maybe listening to our roundtable to fight the disease. And also, if you could see implication and also challenges, and there are some challenges that emerge, and also differences, because you are a very particular observer from your global perspective. So if there are differences between regions, for example. Thank you for joining us.
Yeah, thank you, Beatrice, and thank you for mentioning our report, which doesn't show up so great on the green screen. I'll put it in front of me there, for best practices in liver health policy. We did just release this at a side event at the World Health Assembly 77 in Geneva, and with a host of multidisciplinary partners that joined us there. And so, to answer your question, there were a couple of questions in there, actually, Beatrice. And so let me say that I think that when we look globally at everything, we have much more in common than we do have differences. And when you look at liver disease, it really comes down globally to 4 basic things: prevention, identifying those at risk, screening, and then treatment. Those 4 areas. As Alba said, we've never really done prevention very well in any capacity, whether it's individual prevention, such as working on drinking. We see it in other areas like tobacco, where there's got to be more legal authority or regulatory authority involved. But even our systems, whether it's our food systems or our physical infrastructure, we still have a lot of work to be able to do there. And we see that globally also. But when we take a look at other areas, when we gathered our folks in Geneva, we had individuals from the obesity sector, from cardiovascular, from diabetes, from all sorts of different places where liver disease has touch points. And we find that we really do have a lot in common. I would note specifically in terms of best practices, that's the hope of our report, which you can find on our website, to plug it, is that, I think in these areas, in these 4 areas, where what we find is we want to emphasize where there's innovation that's happening in individual countries that may not be waiting on regulatory authorities or pharmaceuticals to be able to provide us with an answer. An example of that would be, we focus on this in our report, in Ireland, for instance. Ireland, a couple of years ago, they did a project where they screened diabetes patients for NAFLD, but they used community pharmacy data to be able to do that. And so that's data, as I said, we have the data, it's already out there, but to come up with the innovation of how do we combine that? And they combined pharmacy data with transient elastography. And then what they found with that is basically 4 in 5 individuals identified through the screening had some sort of sign of diminished liver function. 1 in 5 actually screened for advanced fibrosis or cirrhosis. And so that's available data. It's easy to do. It doesn't require a new non-invasive test or standard to be able to do. It doesn't require biopsy. It doesn't require medication. This is identification and screening. And what's important for this, for the Global Liver Institute, is so often we get, kind of stars in our eyes talking about AI and talking about the latest diagnostic technology. But at the end of the day, we are trying to raise up best practices that can serve our most at-risk populations in the worst case scenarios. And so what works in rural Appalachia in the United States, what works in perhaps an underserved section of a major city in Europe or in Eastern Europe, what works in Southeast Asia, what works in rural Africa, if we can find these simple answers in there. And I think there's also places we can learn from there, which is why we want to emphasize best practices globally. Maybe there's something happening in Kenya that we can export to Mexico and adapt it just a little bit differently for their regulatory scheme or for their cultural consideration. And I think when you combine the lessons learned from obesity, from diabetes, perhaps even hepatitis and some of the HCC treatment as well, we are optimistic about what the future holds.
Thank you. So let's stay abroad. Michael, thanks for joining us from Canada in this case. So we heard from Professor Gomez the multidisciplinary approach that the Grip-on-Mesh project tried to put in place. And today, this roundtable is composed by people coming from having different background and coming from different fields. So it's clear that the collaborative effort should be a priority. And I would like a comment from you by that. And more or less, I would like to ask you the same question that I asked Jeff. So if you got in touch with innovative approaches or initiative and you've been involved in something that is really meaningful to tackle the disease.
Sure. Thank you, Beatrice, very much for that. Collaboration and the collaborative efforts between stakeholders is so important. It's really a key issue in addressing fatty liver disease. And a lot of that is because it is involved so closely with the metabolic comorbidities. And so it makes it more complicated. And so I wanted to share 4 different categories of collaboration. I think that might make it clear for people. The first one is about comprehensive care. So if we're looking at healthcare providers as an example, the primary care physicians, this is what we talk about a lot, right? As an initial thing, primary care, dietitians, hepatologists, endocrinologists, behavioral support is something that's really important now. And all of that really providing care for patients, and a lot of it around, like we talked about earlier today, lifestyle guidance. The second area is about researchers, and it's important for researchers to offer insights into latest treatments and understanding those disease mechanisms. And of course, the patient organizations are important. I have a bias there, but supporting patients with resources, education, and advocacy. So the second major pillar or area of focus is the improved research and treatment side of it. And I've been to a lot of meetings around the world now, and that shared data, the collaboration between investigators, pooling data for patient data so that they have larger samples and can lead to larger, more robust studies. And that's really, really important. And also it supports innovation because we have joint efforts that can help accelerate the development of new treatments for patients. The third area, and GLI is very focused on this, Jeff will attest to, the policy and advocacy side, having a unified voice and this coalition of stakeholders can make a real big difference because we can lobby together. And that was seen this past year when we did a number of things together with the GLI. Public awareness is also really important because we can raise awareness together, reduce stigma, liver stigma associated with fatty liver disease. And under the Liver Action Network, we have 14 organizations, and we really focus a lot on trying to coordinate efforts. And the fourth area is about support for patients and the education side of it. And remembering that patients are people. Physicians are people, we're all people. And so you have to take a holistic approach and integrate that medical advice into a tailored care approach. It's just so important. None of us are going to react the same way to any of the possible therapies. And then the second part of that is the empowerment for patient organizations, having their individuals have the knowledge and the support networks that they need. Just a comment too, before I get to the second part of the question, is about how we can maybe enhance some of those. And I just thought of a few things to share. Regular communication, which a lot of us do at least monthly, but probably more often than that. Interdisciplinary team development, if there isn't across like globally, internationally. Shared goals and metrics are important. There may be opportunities for initiatives like joint initiatives and grants so that we can work together on different projects. We talked a little bit about technology and data sharing a little bit today, and that's important as well, with maybe with new apps. Patient-centered approach, involving patients in the decision-making process, and again, educational programs. So you asked also about the some examples that we're doing in Canada. I wanted to share 3 that we just did in the last little while. The first one was a series of 10 educational videos for patients with, and Jorn was actually one of the speakers, where patients who knew that they had mast cell MASH could be given a lot of information that could help understand the disease, how it impacts them, how to talk to doctors, that type of thing. And so that went over really well. We've also done one as a pilot, an in-community event with about 60 people where we had specialists come in. We taught them about liver disease, fatty liver disease, and then we had a FibroScan assessment, and we were able to do maybe 15 or 20 that last time. We're doing another one for Global Fatty Liver Day on June 13th, and we have now 90 people confirmed already. I'm trying to get 100, and we have 2 FibroScans, 2 technicians, so we're doubling it up, and I'll let you know how that goes. And lastly, every year we've had 2 primary care mast cell MASH summits, and we've had 2, and we have another one on December the 5th. So we're doing, I think, quite a bit to try to bring people together and to share information.
Great, thank you. So I see that Vicky is back. So I just give her a couple of seconds to reappear. Vicky, can you hear us? If not, I can. Can you hear me? Hi. Yes, perfectly. I cannot see you actually, but now yes, probably. Yes, perfect. But your microphone. Perfect. Thank you, because it's I'm staying with on this topic.
Having something.
I cannot hear. Try to speak. Yeah, try to speak, Vicky, because for me it was very difficult to hear. But maybe it's just me.
Can you hear me now?
Now a bit better.
Yeah, I think it's a little bit frozen sometimes.
Yes,
there is
Vicky,
not a very good connection.
Your voice, how's your connection? Because I cannot also see you, a bit blurred. But so if you want to try to reconnect, we can maybe continue. Yeah, she froze, but maybe she
I've
will
just
try.
with network. Can you hear me now?
A bit, yes. We can try, or you can try to reconnect.
I will try to
Yeah,
reconnect.
perfect. So but this is interesting. Because Michael, you mentioned a couple of times primary care, and regarding the interplay with other non-communicable disease, and we mentioned type 2 diabetes, we mentioned obesity, we mentioned cardiovascular disease. This is a very complex, it should be very complex managing a patient with this, let's say, with this profile. So for Professor Schattenberg, which are the implications from a medical point of view on this very complex, probably patient to be treated? And my question regarding primary care is a bit out of the blue because Michael mentioned it. As a patient association, for us, it's very difficult also to educate primary care doctor about this disease. And we are trying, together with Michael, a part of our campaign this year is dedicated to them. So I would like to know your opinion on that.
Thank you, Beatrice, and thank you to ALPA for inviting me and giving me the opportunity to give my opinion here today. I have to say I strongly agree with what's been said previously, in particular by Professor Cortes Pinto, and also Jeff of McIntyre, of course, on the role and importance of highlighting future preventive strategies to avoid adverse outcomes. And as a physician in clinics, I see liver cancer every day. And I think back that this could have been prevented 15 years ago if the patient would have been educated or would have had access to healthier foods, better nutrition. I think there's a certain disparity here that we need to address urgently as a society. From the physician's point of view, you mentioned it's complex. I think it's fairly easy and straightforward. We have clearly defined risk populations. We have worked hard as a field to develop tools, and these are available today. And as such as a field, I think physicians are capable to provide liver health and identifying patients at risk. And we need the empowerment of the healthcare systems to actually provide that liver health. So here I think political activity is being required in the general healthcare systems. That's different. We do not want to burden all patients to have to buy their own health tests. That's a problem. So I think we have the tools, we have the knowledge, and we clearly would be happy to guide where to install this. So the future could look bright, and I think we need political sense and political willingness to implement this.
Thank you. And I see Vicky is back, and she's also nodding. So it's the perfect moment to ask you a question. So we saw the connection between the liver and obesity. But I would like to ask you, thanks. I mean, the fact that you are here, it proves that we need to work together. that's certainly a statement that we should say upfront. So how aware are people living with obesity about their liver health, about the risk of developing fat accumulation in the liver and all the consequences that this has, and which resources, which kind of support do you think would be the most effective in helping patients living with obesity understanding and addressing their liver health? And so also, if you can then say something about stigma, because I know that this is very important for your community and for my community.
It's a huge topic, and thank you, Beatrice. Thank you so much for having me here. Apologies about my connection. We're having some maintenance done at home. And like Jeff, I'm just home from the World Health Assembly, and probably not as awake as I should be. Firstly, I actually wanted to compliment GI on GLI for their event, their side event that took place at the World Health Assembly, which was quite remarkable and spoke to not only liver disease, but also obesity. And this is unfortunately what we see in the obesity areas. So unfortunately, liver disease and obesity as NCDs, they live in this myth and misconceptions world where everybody assumes that obesity is down to laziness, gluttony, eat less, move more, you'll be perfectly fine. Liver disease is just alcohol, right? That's what the average person believes. It's just you're drinking too much. And that is a societal narrative, unfortunately. Now, we actually have a multi-billion-dollar fitness and diet industry out there. And we have all of these influencers and social media targeting our youth with a one-day course where they believe they are suddenly a healthcare professional and they are Dr. TikTok, Dr. Google, Dr. YouTube, and that is a huge part of the problem. We need to change that narrative in society. But the problem that we also see is that our patients in the obesity community are not aware at all of the increased risk of MAFLD or MASH. They have no idea of it. This is something that is really, really new to the patient community, especially in Europe. They don't see the links. It is only now that we're realizing that obesity can be unfortunately, a gateway disease to many other disease areas, such as diabetes type 2, such as MAFLD, cardiovascular disease, so on and so forth. So this is where our communities actually need to collaborate. And unfortunately, our media plays a huge role in what they're pushing out to society and how they're delivering the stories on liver disease and obesity. And, you know, in many ways, we try to encourage our patient community to say, well, look, you know, and actually, as I looked at this, Jeff, as I went through this, and I looked that you did the study on Ireland. So I was very appreciative of that because Ireland's actually estimated to become Europe's most overweight nation in the next year, right? And then as we go through it, I know, Jeff, you had said 4 in 5 individuals identified through the screen had signs of diminished liver function. However, 1 in 5 actually had advanced fibrosis already. And these are type 2 diabetes who have no awareness at all that liver screening is so important. So many of us try to say, right, we need to educate our patient communities. We need to work with ELPA, which we are doing now for the last year and a half. Thank you very much to ELPA, Marco and Veronica and Milan and all the work that we've been doing collaborating. But it's like educating the patient to go to their primary healthcare provider, and their primary healthcare provider isn't ready to actually put something in place for them and gives them the eat less, move more, no liver screening, no other checks, no advancement, unless they are a part of this, I think, this bubble that we are all in. And that education kind of needs to get outside. Probably the biggest challenge that I have is that we did a study, an Action IO study on obesity across 10 countries globally. And the average person waits 6 to 9 years to actually attend their GP or their primary healthcare provider for obesity. Now, if they're waiting 6 to 9 years just for that, at what point then are they going to get their liver screening? Are they going to have a conversation around that? Is it going to be diagnosed and tested? And that is a big problem that we have. And a lot of that comes down to, as you say, the stigma. So the stigma that exists that it's your fault, you're drinking too much, you're not eating properly, you're not exercising enough. But if you look at the obesity community, people with obesity, this is why we have the multi-billion-dollar industry of fitness and diet. They are constantly on diets. They are constantly trying the latest innovations and the latest gym equipment, and they're constantly pushing themselves, but society sees them as a failure because when they don't lose enough weight, they regain weight. And then it's like, you have failed. People do not fail. Treatment fail people, and our educational system, our policies that are in place, and our policy gatekeepers, they are failing people. So that's where we need to move.
Thank you. I'll stay with you since your connection is perfect now. so yeah. I'll take. Yeah, I don't want to lose the momentum. So can you like sum up for us some barriers that people living with obesity have in accessing healthcare and receiving appropriate treatment and related also to their liver? And you mentioned stigma, and I think also the structural stigma, so the stigma that they can encounter in healthcare facilities is one of them. But yeah.
Thank you so much, and apologies if my connection goes. We're having maintenance done, so it's all a little bit crazy here at home. Regarding barriers, I would say our number one barrier is stigma. And that stigma is existing in not only the societal narrative and belief that obesity is just a lifestyle disease, but also it sits in so many of the policies that are created by, I don't call them policy makers or decision makers, I call them gatekeepers, because effectively they're the ones that choose whether or not to actually take the stigma out of the strategies they have put in place. If you go through and look at the national prevention strategies for obesity for majority countries in Europe, they are all eat less and move more. That is just public health awareness for everybody. No matter what NCD you have, you are told to eat healthier and exercise and take better care of your health. That is just public.
Well, no, maybe she will be back. Yeah, she's back.
That is not effective for obesity. That's almost like you're saying to somebody who has skin cancer, here is a hat and here's.
No, she disappeared, but just a comment on that. Maybe Alba, you know better than me. Not all the EU countries, but I can ask her. Vicky, you mentioned guidelines about obesity. Not even all the EU member states have guidelines about obesity. Is that correct, or it's an old information that I have?
Sorry, can you say that again, Beatrice?
So you mentioned guidelines about obesity, and you mentioned that are focusing only on what we were saying at the very beginning with Alba. So just eat less eat better. But is it correct that not even all the member states have guidelines about obesity, or it's an old?
No, exactly, and we're delighted that now that Canada has published their clinical practice guidelines, that Ireland have actually taken that on board and they've adapted them for Ireland. So we have clinical practice guidelines there, and we've many other countries that are following suit. So this will help the momentum, and this will help change and support for people to actually get access to the care that they need.
So guidelines can be also something us as patient association, we can advocate about.
We can indeed, and that's been a priority for ICPO, the Irish Coalition for People Living with Obesity in Ireland, who worked with the scientific community there and the HSE, the health service, and they've actually been a part of creating those guidelines, adapting them for people in Ireland. And Ireland's a very small population of just over 5 million. So I can only imagine when it comes to the likes of Spain and Germany and other countries that have populations, how difficult that will be, because people with obesity need personalized treatment, just like people with any other liver disease or diabetes type 2, they need personalized treatment and support. So hopefully these guidelines and our policy gatekeepers won't stand in the way. Hopefully that will actually make a difference and a change.
Thank you. So we are running a bit out of time, but I will go back to Professor Pinto and back to the topic, the alcohol topic that we touched upon at the very, very beginning. What are the challenges in distinguishing between alcohol-related and non-alcohol-related, let's say, fatty liver disease? So we are still in the new nomenclature framework, and how healthcare providers effectively address the diagnosis, but also the treatment of these patients.
Thank you very much for this question. In fact, I think it's very complicated. I think that there are these three, the MASLD, the METALD, and then the designation of alcohol liver disease. I think there are mainly the questionnaires. The questionnaires are time consuming, and then there are the blood markers that are not available everywhere. It's not so easy to have them available on a regular clinical practice. So I think that to distinguish from MASLD to the METALD, it's not so difficult. But then from what is let's say the latest part of the METALD and what is to be considered just alcohol liver disease, I think it's very, very much difficult, because if you want to quantify if a patient drinks 60 grams a day or drinks 100 grams a day, here in ALT predominantly you have 350, 420 a week. And this is very, very difficult. So I'm not sure if the issue of the nomenclature is still a work in progress, and I'm not sure to which extent we will keep exactly these numbers. I'm sure that from differentiating MASLD from METALD, yes, it's rather easy, because also we are more in the use of doing it because we distinguished from NAFLD. But then I'm not sure to which extent all the patients that have significant alcohol consumption and metabolic risk factors will not have to enter, let's say, the same box. And that is also important for treatment-related issues, because it may be needed to use the group of patients that now are MASLD, where alcohol almost doesn't enter. And then, of course, for clinical trials, we can differentiate different levels of consumption. But in clinical practice, I think it's difficult to put them in separate boxes. But of course, I think patients have interviews with a nutritionist, or it may be possible in the future, but until now, I think it's rather difficult. Although I have some hope in these tests like the ethylglucuronide or phosphatidylethanol, but I think it will not be easy.
I'll drift a bit away from my questions, the order of my question, since we describe, we talk about the new nomenclature. Professor Schattenberg, there is a new SLD nomenclature, is 1 year old. The patient community patient communities are happy about the new nomenclature, but probably Professor Pinto is right, it's a work in progress. So what are you expecting from the future? Where are we standing, and what also liver patients should be expected in the future?
Yes, so the nomenclature was an important milestone to be reached. There was a lot of discussion in the past about the best way to define the disease based on the pathophysiological criteria. And I think it was very clear that using negative criteria, calling a disease what it's not, wasn't a good way forward. Then there was a strong academic debate, and I think academics love to debate. That's in the realm of science. This will for sure be supplemented by additional data over time. But I think the important message is that we have an agreed nomenclature moving forward with some of the large professional associations that cover a lot of physicians worldwide in the US and Europe. And for me, this is a very strong message. As a matter of fact, when I go talk to my colleagues now and I train them about metabolic liver disease, they say, well, I can relate to that. And now I know which patients you're talking about. In the past, they always mentioned there is nothing like non-alcoholic. And that was the important step here. In addition, there was a lot of discussion around cultural background and stigma, and patient advocates gave input, and I think they're in a better position to comment. I don't oversee all of that. Cultural aspects are important, bottom line, I'm very happy with this nomenclature, and I think as an academic field, we'll generate data and link that to important endpoints, which in the end we want to affect for the better of our patients.
I have a very, maybe it's a very silly question. Is it helping you in your daily, so did you see a difference in how are you treating patient, in how are you diagnosing patient in your daily practice?
Yes, good question. And it does, definitely, because by calling this disease metabolic, it's a little bit of a difficult term for a patient, maybe.
Yes.
But they can relate to it better than calling it non-alcoholic, because the alcohol stigma has been omnipresent, and in particular, even women were more affected and crying out every time I termed or tried to pinpoint their liver disease. So I think it has clearly, from my perspective here in Germany, and again, there might be cultural aspects across the globe, it has clearly helped me to define the patient population, to communicate about the disease, to tell them that it is their metabolism that leads to this disease, and that I think helps them to focus on some of the treatment goals we are agreeing on together.
Okay, so we are entering the domain of the future. So Professor Gomez, is there out there some promising research or are there some emerging technologies that we should be aware of that can help preventing or detecting, maybe not only steatotic liver disease, but in general, maybe liver disease, related to the SLD?
I think in the three key points in the management of this disease and opening the door to the future is the awareness, the screening, and the treatment of this disease. I think in the last few years, we improved a lot the definition of the guideline, what is the best manner to detect patient and to refer. We are very happy because we had the first drug approved by FDA, the resmetirom, that allow for a subset of patients promising drug able to promote fibrosis regression and MASH resolution. And finally, the key point that we need is the awareness, in which ALPA is playing a major role, and we need to engage everyone belonging to the general society to be part of this big problem. No, and I think I'm very happy due to that, because we have a very clear pathway that we need to implement. We need to work on how can we reach as much people as possible, but we know what we need to do. The second is what is at this time the best manner to manage the disease. We need to implement lifestyle intervention, increase or improve the healthy diet, that people need to be active physically, doing exercise, no marathon. We don't need people to go to the Olympic Games this summer, but people that avoid sedentarism. And I think the consolidation of this concept are the key point at the basement for the development in the future of more effective drugs that I'm sure they are coming in the next few years, together with a much higher awareness, able to engage general population in the fight against this disease. I think that the main result is this basement, and I hope if we are addressing these three key points, we will do that. For example, liver biopsy has been for a long time a major barrier in the development of knowledge and the engagement of the general population. Now, fortunately, we are very close to have non-invasive method able to replace a liver biopsy. Indeed, we are not doing in our clinical practice daily, and FDA, when approved resmetirom, did not consider liver biopsy as mandatory. The emergence or emerging non-invasive tests like elastography by ultrasound or magnetic resonance, for example, is a very, very important tools able to better understand the disease, to diagnosis, and to design a prognosis, allowing us in the decision making for the therapy. This is
Thank you. Thank you.
Messing everything.
No, it was really clear. We have the last 5 minutes before going to Vicky, Michael, and Jeff. The patient representative, big heroes. Professor Pinto, we mentioned screening. So we've been fighting for liver screening EU guidelines. I don't know, for years. And nothing is moving on that front, but we are keeping fighting. From your point of view, so we are let's say we are fighting on the political front line. But from your experience, how can screening be implemented in routine clinical practice, and how can we reach people at risk? And also raising awareness about liver screening among the general population.
Thank you. Well, first of all, just to be sure that I agree with the new definition. So I'm completely in line. I think it has helped a lot. It helps me also in my clinical practice, mostly the possibility of having this metal group. So it was just this issue of the quantification. Okay. But now going on to your question, that is very, very important. I think that what we need is very much based on the GPs and on the general practitioners. I think they have to be aware of the importance of liver disease. And first, they have to be able to identify patients that have risk factors. And these risk factors are all those that we mentioned, the cardiometabolic risk factors and consumption of alcohol. After they identify those that have risk factors, they have to evaluate the severity of fibrosis. So for me, it doesn't matter so much if they have steatosis or not. They have to do these 2 steps. They have to see the risk factors and then evaluate fibrosis severity. And to evaluate fibrosis severity, they can start with very simple methods like FIB-4 or other simple scores of evaluating, and then having good pathways to refer those that they consider are at risk to have secondary or tertiary centers where they can do elastography by one of the many methods there are to do it, and then to move on this path, because we still see, and it's really very sad to see patients coming bleeding from variceal bleeding when with some diseases that advance to this point, and none of these clinical practitioners noticed or did anything, or even the patient came to the emergency room several times and nobody thought about it. But I think the main issue is the GPs, the risk factors, and fibrosis severity. Thank you.
Very clear. Thank you. So Jeff, what's GLI's plan for continuing to address and to raise awareness?
We have 2 main things. One is we will continue to support and empower patients globally and caregivers as well. We already have materials in 18 different languages as part of Global Fatty Liver Day for patients with MASLD and fatty liver disease. And so we will continue to support them and all of their needs. The second one is that as we have seen pharmaceutical therapies begin to come out of clinical trials, we can now start laying the groundwork for the important next steps. And as was mentioned earlier, for Rezdiffra, the FDA indicated that a biopsy would not be required, but we have seen that actually the Veterans Administration in the United States did recommend biopsy. We are hearing several private insurers are recommending biopsy here in the US as well. And that's a troubling precedent for other therapies that are in the pipeline right now. And so we'll be working on that and working on just making sure that we have patient access. And so this therapy coming out now is great because we can start working on patient access in the United States, but also using that as a template for access and education in Europe when it comes in front of the EMA, as we go to Latin America with Mexico, Colombia, and Brazil, and into Southeast Asia as well. And so this is a pebble in the pond with reverberating rings. And so now we're looking forward to good new directions for patients and creating lots of options and a lot of support.
Michael, future of patient advocacy from your perspective.
Well, I think we're off to a fantastic start. The last couple of years you can see a number of things improving exponentially. Increased awareness and education, it's happening everywhere. Patient involvement in clinical research design is new, and it's happening more and more now. The use of social media for education, some of the new apps and online information sharing. Policy advocacy is something that's again, I'll pat GLI on the back for their A3 course, which is very helpful. And I mentioned before this holistic patient support. So I think it's really important to think about patients. And so all of those areas are doing much better, and we're off to a really great start.
Vicky, priorities from your point of view, and for the patient living with for the people living with obesity.
I think the biggest priority right now for us is to collaborate with your community and the diabetes community and ensure that patients are made aware, but also make sure the patients that are made aware of the risks, that they do not stigmatize their own GP or primary healthcare provider for not understanding that obesity is a chronic disease, that liver disease is, a high risk factor. Diabetes type 2 is also. So it's educating the patients, working together, collaborating. Our voices are so much stronger when we actually come together as NCD communities. So that's really important for us.
The very, very last question. We cannot ignore the fact that we are 8 days away from the EU election. So Alba, you have the honor or the burden to to address the last question. And the last question is about the future direction for EU public health policy in combating the growing burden of non-communicable disease.
It's an honor. It's an honor. I think we need to understand that what is not good for the bee is not good for the hive when it comes to health and when it comes to non-communicable diseases. And of course, we need specific legislation and specific strategies, but we need to act together, and we need to bring the public health community together, and we need to bring diabetes organizations, liver organizations, obesity, Alzheimer's, cancer, mental diseases together, and because together is how we are strong. And these diseases are caused by systemic complex problems, and they need systemic solutions. And we need to understand that we don't compete, but we complete each other. And I like what Vicky said, is not the people failing, it's treatment failings, and it's policymakers failing and policymakers. And when it comes to public health, right now, it's a political choice. And we need to make accountable to the policymakers, and we need to make healthy by default. Right now, if being healthy, it's the difficult part, we need to make it the easiest. And if you want to be unhealthy, that's okay, but then you need an extra effort. Right now, it's the other way around. So we need to act together. We need to set health high in the political agenda. And of course, we need funding for that. We cannot do this if we don't have multi-annual financial frameworks, especially at EU level. So this is my message. We need to act together. We need to have one strong voice, and we need to keep policymakers accountable.
Thank you very much. Thank you, everybody. Since I have the pleasure to wrap up, No, Professor Romeo. Oh, yes. So you were not the last one.
Yes, I'm sorry, Alba, because it could be much better you are the last, but I cannot avoid this opportunity to share with you the Spanish strategy for liver health that we are dealing with the Spanish Ministry of Health. We were working in the last year together with the FNET, with the Spanish Association for Patients living with liver diseases. And I don't know, but perhaps we can share with you this plan, this national plan, trying to promote this activity in the different countries, or even just one strategy across Europe. We divide the main liver problems, and we try to address the key points according to a SWOT analysis. I'm not using more time, but I think it could be quite interesting. This excellent relationship between patient association and the academy and the industry will allow us to address an European plan to improve liver health, and just to have this opportunity to share with all of you.
Please share. Thank you.
Thank you. So I prepared a long paragraph for closing remarks, but I think that the most important closing remark that I can do is to thank you all, certainly for your participation, certainly for your expertise, but I think that on top of that, I have to thank you for your commitment, because I know that you've been dedicating your professional life, and sometimes even more, just even part of your personal life to liver health or to public health or to patient engagement and of course to medical research and to clinical practice. So thank you all for joining ELPA today.
Thank you all.
Bye-bye.